It's a pleasure to be with you. The title of this session is COVID-19 Public Health Strategy Basic Concepts Part 2. This session reviews several key response and mitigation concepts as they applied during the progress of the COVID-19 pandemic. There are no disclosures for this presentation. Objectives include discuss the concepts of herd immunity and serologic data. Discuss how cocooning protects high-risk individuals. Discuss concepts of home isolation. Review COVID vaccines and medical therapeutics. Discuss key concepts of crisis communications in pandemics. Review the importance of triage and review home monitoring concepts. There are three phases to the COVID-19 pandemic: the pre-vaccine phase, post-vaccine phase, and endemic phase. In part one, we discussed the pre-vaccine phase, discussing the COVID organism and disease and concepts to decrease transmission. In this session, we will continue to discuss decreasing transmission and protecting vulnerable individuals, the post-vaccine phase, including a brief discussion of COVID treatment and COVID vaccine communication strategies. Herd immunity or community immunity is when a large part of a population group or community is immune to a specific disease. If enough people are resistant or have immunity to an infectious agent like COVID-19, that broad immunity provides a zone of protection around those who are susceptible as diagrammed. While not every single individual may be immune, the group as a whole has protection because there are fewer infection-susceptible people overall. The infection rate drops and the disease terminates in that community, since the virus can't reach susceptibles to perpetuate its life cycle. So herd immunity protects at-risk populations. There are two ways to enhance the herd immunity in a population group. One, catch the infection and develop natural immunity. And two, vaccination. When does a community reach herd immunity? It depends on the reproduction number, or R0 in epidemiology. The R0 describes the average number of people that a single person with a virus can infect if those people aren't already immune. The higher the R0, the more people need to be immune to reach herd immunity. Currently, it's thought that the R0 for the COVID-19 Omicron variant is between 12 and 18. This means that one person can infect 12 to 18 individuals. Using this number, we can calculate that 92 to 94% of the population would need to be immune before herd immunity kicks in and the infection rate starts to go down. The initial COVID organism had an R0 value of 2 to 3. The Omicron variant is much more transmissible than the original COVID organism. There are two simple formulas for calculating the COVID-19 herd immunity threshold percent. One formula is herd immunity threshold equals R0 minus 1 all over R0 times 100. The other is a different way of stating the same formula. Herd immunity threshold equals 1 minus 1 over the R0 times 100. So using the first formula, the low COVID-19 herd immunity threshold percent using a reproduction number of 12 would be 92%. The high COVID-19 threshold percent using the reproduction number of 18 would be 94%. So between 92 to 94% of a community would need to be immunized or have natural immunity to reach the community or herd immunity threshold. Once this threshold is reached, there should be a decline in transmission for COVID-19. The herd or community immunity threshold, HIT, is impacted by the efficacy of COVID-19 vaccines, the vaccine efficacy coefficient, VEC, available to a community. The vaccine efficacy coefficient, VEC, equals 100 divided by the vaccine's efficacy to prevent transmission as a percent. For example, if COVID vaccine A has a vaccine efficacy to prevent transmission of 95%, then the VEC would be 100 divided by 95, which equals 1.05. The VEC is then multiplied by the herd immunity threshold number, HIT, to get a vaccine-adjusted HIT. So if the COVID-19 HIT is 92%, then the vaccine efficacy-adjusted HIT for vaccine A would be 92% times the VEC for vaccine A, or 1.05, which equals 96.6%. If the community is using a different COVID vaccine B that has a vaccine efficacy to prevent transmission of 85%, then the VEC for vaccine B would be 100 divided by 85, which equals 1.18. The vaccine efficacy adjusted HIT for vaccine B would be 92% times the VEC for vaccine B, or 1.18, which equals 108.56%. So with a vaccine efficacy of 85%, it would be impossible to reach the HIT threshold of 92%. It's important to consider vaccine efficacy to prevent transmission when calculating herd or community immunity thresholds. To identify the number of people in a community that have been infected at some time with COVID and have some natural immunity requires testing individuals for antibodies to COVID-19 via a blood sample. Ideally, all individuals in a community would be tested by serology for immunity, but that's not practical. Taking a random sample of a community or group members is a reasonable alternative. This slide lists 4 common steps for a random sampling process. First, define the population, community or group to be sampled. This is the big N designation when using a sample formula, which will be discussed in a few minutes. Next, determine sample size, expressed as the small n in the formula. This sample size number may be chosen based on budget limitations or time available to do the study. Most statisticians agree that the minimum sample size to get any kind of meaningful result is 100. If the total population is less than 100, then everyone in that population should be studied. A good maximum sample size is usually around 10% of the population, as long as this does not exceed 1,000. For example, in a population of 5,000, 10% would be 500. In a population of 200,000, 10% would be 20,000. This exceeds 1,000, so in this case, the maximum would generally be 1,000. Even in a population of 200,000, sampling 1,000 people will normally give a fairly accurate result. Sampling more than 1,000 people may not add much to the accuracy given the extra time and other resources it would cost. For more accuracy, lean toward the maximum sample size. With less resources, lean toward the minimum sample size of 100. The table in this slide can also be used to help determine sample size based on the margin of error desired for the study and the size of the population. This slide includes a formula for more accurately calculating an adequate sample size. Small n equals z squared times p times 1 minus p all over e squared. That quantity divided by 1 plus z squared times p times 1 minus p all over E squared times the large N, where small n equals sample size, large N equals population size. Z is the z-score, a constant value based on the confidence level chosen. The confidence level represents the degree of certainty the sample represents the population. The most commonly used confidence levels are 90%, 95%, and 99%, as demonstrated in the table. The E value is the margin of error wished in the result. It is also known as the confidence interval, or CI, expressed as plus or minus a percentage, like plus or minus 3%, or plus or minus 5%, etc. The E value determines how close the sample result will be to the true population value. The standard deviation states how much variation is desired in the formula. 0.5 is a common standard deviation used in population studies. This is one website that calculates the sample size for a study population by plugging in key values for the formula. After selecting the sample size, assign sequential numbers to everyone in the population, also known as units. Identify the sample units by utilizing a randomization process. These random numbers identify unit numbers in the population selected for the study sample. This slide demonstrates how to use a random numbers table to select a random sample from the population units. Let's assume we want a sample size of 250 from a population of 900. We would just point to any number on the table to choose a starting point for the random sample. For example, the number in the box 93129. Since we have 3 digits in the population unit number, we will start from the right-hand side of the number chosen to start our random sample and read the last 3 digits. In this example, 129. That will be the first unit number in our sample of 250. We would then move to the next number down, 59208, and take the last 3 numbers, 208, for our second random sample unit. We would continue this process until we reached our 250 target. If any number is greater than the population number, 900, like one outlined in red, 997, then skip to the next number, etc. This process is cumbersome but works. Utilizing computer randomization tools like those in Microsoft Excel program, etc., is much more convenient. While simple random sampling is one of the gold standards of sampling techniques, it has advantages and disadvantages. The aim of the simple random sample is to reduce the potential for human bias in the selection of cases to be included in the sample. As a result, the simple random sample provides an adequate representation of a population being studied, assuming that there is limited missing data. Since the units selected for inclusion in the sample are chosen using probabilistic methods, simple random sampling allows for making generalizations or statistical inferences from the sample to the population. This is a major advantage. A simple random sample can only be carried out if an accurate and complete list of the population is available. Attaining a complete list of the population can be difficult for a number of reasons. Even if the list is readily available, it may be challenging to gain access to that list. The list may be protected by privacy policies or require a lengthy process to attain permissions. There may be no single list detailing the population you are interested in. As a result, it may be difficult and time-consuming to bring together numerous sublists to create a final list from which you want to select a sample. Many lists will not be in the public domain and their purchase may be expensive. The process of contacting people or sample units is commonly expensive and time-consuming. Managing the different ways of contacting the sample units, like by direct mail, telephone, email, direct visits, etc., may be challenging. Sample units may be geographically scattered. To avoid potential bias, ensure that an adequate proportion of the chosen sample participates in the process. This may require recontacting non-respondents or reaching out to new respondents, which can also be time-consuming. Strategies to do randomized serologic testing should be developed by states as part of their response to pandemics similar to COVID-19. Let's now discuss some concepts to protect the most vulnerable in our communities. Protecting the most vulnerable will significantly address the major goal of assuring adequate medical care for the moderate and severely ill. Individuals 60 years old and older and those with underlying medical conditions are the people who are most likely to get severely ill and need hospitalization and intensive care. Protecting them will help flatten the curve and keep the pandemic from overwhelming our healthcare system. A major strategy to protect the vulnerable is focusing resources and media messages to provide a cocoon of protection around this group, insulating them from infection. This strategy may have several parts, including hardening long-term care facilities, enhancing support for the vulnerable when on home isolation, and decreasing transmission in the general population. Let's now consider hardening long-term care facilities for a few minutes. Long-term care facilities can be hardened by restricting access to the facility and implementing and monitoring strict facility infection control measures. These next several slides cover restricting access and implementing strict infection control measures prior to COVID vaccine being available. One of the most important tools to protect long-term care workers and patients is COVID vaccination for staff, patients, and patient families. This slide covers key Centers for Medicare and Medicaid guidance for restricting access or visitation to long-term care facilities. Facilities should notify potential visitors to defer visitation until further notice via signage, calls, letters, etc. Facilities should restrict visitation except for essential healthcare personnel and for certain compassionate care situations such as end-of-life situations. Decisions about compassionate care visits should be made on a case-by-case basis. Approved visitors, including family and end-of-life situations, clergy, bereavement counselors, etc., should be carefully screened. Those with symptoms of a respiratory infection, fever, cough, shortness of breath, or sore throat should not be permitted to enter the facility at any time, even in end-of-life situations. When allowing a visitor for those compassionate care situations, they should be limited or restricted to a specific room only for the visit. Visitors should be required to perform basic infection control measures, including hand hygiene frequently during the visit and using personal protective equipment, PPE, such as face masks. Visitors should be reminded to refrain from physical contact with residents and others while in the facility, practicing social distancing, including no handshaking or hugging, and remaining at least 6 feet apart. Facilities should disinfect rooms after each resident-visitor meeting. In lieu of visits, facilities should consider offering alternative means of communication for people who would otherwise visit, including various phone or other virtual video conferencing platforms, etc. provide a communication system to update families like listserv, website, text, voicemail, etc., and assign staff as a primary contact to families for inbound calls and coordinating regular contact with families. Additional infection control measures to harden the facility would include 1. Cancel communal dining and all internal and external group activities. 2. Implement daily active screening of all residents for fever and respiratory symptoms. 3. Remind residents to practice social distancing and perform frequent hand hygiene. 4. Screen all staff at the beginning of every shift for fever and respiratory symptoms. Actively take temperatures and document absence of signs and symptoms of respiratory disease. Any staff members with fever or respiratory symptoms should put on a face mask, self-isolate at home, and be tested. 5. Staff that work at multiple facilities like agency staff, regional or corporate staff, etc., should be restricted as much as possible from working in a facility to decrease the risk of transmission. When in a facility, they should be screened at the beginning of their shift like other staff members. 6. Facilities should review and revise how they interact with vendors and receive supplies, interact with emergency medical personnel and equipment, transportation providers like when taking residents to off-site appointments, etc., and other non-healthcare providers like food delivery, etc., and take necessary actions to prevent any potential transmission. For example, do not have supply vendors transport supplies inside the facility. Have them dropped off at a dedicated location like a loading dock. Facilities can allow entry of these visitors if needed, as long as they are following the appropriate CDC guidelines for transmission-based precautions. 7. Advise visitors and any individuals who entered the facility, like hospital staff, to monitor for signs and symptoms of respiratory infection for at least 14 days after exiting the facility. If symptoms occur, advise them to isolate at home, contact their healthcare provider, and immediately notify the facility of the date they were in the facility, the individuals they were in contact with, and the locations within the facility they visited. Facilities should immediately screen facility contact individuals and take all necessary actions based on findings. Even with COVID vaccines being available, many of these measures to restrict access and control infectious diseases within facilities are still valuable additional tools to control infections like COVID-19. As previously stated, one of the most important tools to protect long-term care workers and patients is COVID vaccination for staff, patients, and patient families. Let's now consider enhancing support for those on home isolation and quarantine as another way to protect or cocoon the most vulnerable in our communities. During a pandemic, many individuals are placed on home isolation and quarantine. Quarantine applies to individuals who are not infected but have been exposed to someone who is infected. Isolation applies to individuals who are infected. A health professional should assess whether the residential setting is appropriate for home isolation or quarantine, or some other venue would be most appropriate. Considerations for care at home include whether the patient is stable enough to receive care at home, which usually means mild or moderate illness. Appropriate caregivers are available at home if needed. If infected and on isolation, there should be a separate bedroom where the patient can recover without sharing immediate space with others to decrease transmission within the household. Resources for access to food and other necessities like medications, etc., are available. The patient and other household members have access to appropriate recommended personal protective equipment. At a minimum, gloves and face masks should be available. All household members should be aware of and capable of adhering to precautions recommended as part of home care or isolation, including respiratory and hand hygiene. For home isolation, there should not be any household members who would be at increased high risk of complications from COVID-19 infection, like the elderly, pregnant women, those with underlying medical conditions, etc. Young children in the home may increase the chance of household transmission, since it's often difficult for young children to understand and practice respiratory and hand hygiene. Home support coalitions may consist of government agencies, nonprofit organizations, faith-based groups, food pantries, and other volunteers, etc. These home support coalitions organize to provide safe support services for those on home isolation and quarantine, helping supply households with food, medications, household products like toilet paper, soap, paper towels, etc. This support needs to be coordinated and assured in both urban and rural settings to help contain transmission and insulate high-risk individuals from infection. Organizing and facilitating a home support coalition to coordinate these home services will require leadership. Public health is well positioned to do this. Home support coalitions will likely need to operate for months as the various waves or bubbles of a pandemic ebb and flow. Let's now briefly return to decreasing transmission in the general population for a few minutes. We've already reviewed social distancing recommendations to decrease transmission in the general population. Social distancing will not only help insulate or cocoon high-risk individuals, but also flatten the curve in the general population. As previously discussed, this flattening of the curve will help assure that medical care is available for the moderately and severely ill, whether they are from the high-risk group or general population. Decreasing transmission in the general population may be addressed by voluntary and mandatory interventions. Voluntary social distancing for weeks or months will be difficult. Therefore, some mandatory steps will likely be necessary to help flatten the curve. Mandatory steps ordered by governments may consist of local, interstate, and international travel bans, closing borders, mandatory testing, closing of schools, businesses, sporting events, group meetings, beaches, other group gatherings, vaccinations, etc. Both voluntary and mandatory social distancing tools may be necessary to adequately flatten the curve. Let's now discuss the development and distribution of vaccines, therapeutic, and prophylactic medications. Vaccine developers used multiple approaches to develop COVID-19 vaccines, including DNA, RNA, non-replicating vectors, protein subunits, inactivated, and live attenuated vaccines. We will discuss the major vaccines that have been approved by the United States Food and Drug Administration, FDA, and the CDC Advisory Committee on Immunization Practices, ACIP. This table lists the COVID vaccines available in the United States. 2 mRNA vaccines from Pfizer and Moderna, 1 non-replicating human adenovirus vector vaccine from Janssen, one protein-based vaccine with an adjuvant from Novavax, and the special Omicron BA.4/5 bivalent booster vaccines from Pfizer and Moderna, highlighted with yellow in the left column. All 6 vaccines have received FDA and ACIP authorizations and approvals. The Pfizer mRNA vaccine has an efficacy to prevent symptomatic disease of 89 to 100%. The Pfizer vaccine has been approved for those 6 months old and older. It is administered as a primary series of 3 doses for those 6 months to 4 years old and 2 doses for those 5 years old and older. Rare but serious adverse reactions include anaphylaxis and myocarditis. Myocarditis is most commonly seen in young males. The Moderna mRNA vaccine has an efficacy to prevent symptomatic disease of 90 to 94%. The Moderna vaccine has been approved for those 6 months old and older and is administered in a 2-dose primary series. Rare but serious adverse reactions include anaphylaxis and myocarditis. Myocarditis is most commonly seen in young males. The Janssen or J&J adenovirus vector vaccine has an efficacy to prevent symptomatic disease of 66 to 85% and has been approved for those 18 years old and older. It is administered as a 1-dose primary series. Rare but serious adverse reactions include anaphylaxis, thrombosis, and thrombocytopenia syndrome, TTS, which can cause life-threatening clotting of blood vessels, and Guillain-Barré syndrome, GBS, that can cause paralysis. TTS is most commonly seen in females 18 to 49 years old. The Novavax protein-based vaccine with an adjuvant has an efficacy to prevent symptomatic disease of 90% and has been approved for those 12 years old and older. It is administered as a primary series of 2 doses. This statement is from the CDC. In evaluation of potential harms, cases of myocarditis or pericarditis were detected during Novavax COVID-19 clinical trials. Reports of myocarditis or pericarditis were also identified during post-authorization use of Novavax COVID-19 vaccine in countries outside the United States. Ongoing vaccine safety surveillance in the United States and internationally will help assess the possible risk for Novavax COVID-19 vaccine-associated myocarditis or pericarditis. The bivalent BA.4/5 booster is the only COVID booster vaccine currently recommended. A booster dose of the bivalent vaccine is recommended for all individuals who are 6 months old and older for both the Moderna and Pfizer vaccines. The only exception is that the bivalent vaccine is not recommended for children 6 months to 4 years old who have already received the 3-dose primary series of Pfizer vaccine, since they are thought to have adequate immunity from the 3-dose series. The CDC, ACIP Advisory Committee on Immunization Practices now prefers the use of mRNA over J&J vaccine. The Janssen vaccine prevents fewer COVID-19 hospitalizations, ICU admissions, and deaths. More severe health impacts from TTS, thrombosis with thrombocytopenia syndrome, and GBS, Guillain-Barré syndrome, are seen as adverse events after Janssen COVID-19 vaccine compared to impacts from myocarditis after mRNA COVID vaccines. So in a setting where mRNA and Janssen COVID vaccines are both available, benefit risk balance for mRNA COVID vaccines is more favorable across all age and gender groups. The Advisory Committee on Immunization Practices has established one small exception to minimum intervals, the 4-day grace period, that allows vaccine doses administered up to 4 days before the minimum interval or age to be counted as valid. The grace period should not be used when scheduling future vaccination visits. Individuals who have had symptomatic COVID disease or have been asymptomatic test positive should be vaccinated, but vaccination should be deferred until those individuals are out of isolation and symptoms are improving. Quarantined individuals should be out of quarantine before being vaccinated. An exception to the quarantine recommendation would be individuals living in a congregate setting like long-term care, homeless shelters, corrections, etc. These individuals should be vaccinated even when they are in quarantine. The isolation and quarantine recommendations are primarily to protect the vaccinators and others attending vaccination clinics. Pregnant women should be vaccinated. The CDC strongly recommends COVID-19 vaccination for people who are pregnant, who are recently pregnant, including those who are breastfeeding, who are trying to get pregnant now, or who might become pregnant in the future. These recommendations align with those from several medical organizations serving people who are pregnant, including the American College of Obstetricians and Gynecologists, ACOG, and the Society for Maternal Fetal Medicine. In the August 13, 2021 MMWR article, the authors stated, a study of COVID-19 infections in Kentucky among people who were previously infected with SARS-CoV-2 or COVID-19 shows that unvaccinated individuals are more than twice as likely to be reinfected with COVID-19 than those who were fully vaccinated after initially contracting the virus. These data further indicate that COVID-19 vaccines offer better protection than natural immunity alone, and that vaccines, even after prior infection, help prevent reinfections. Numerous studies have shown that breakthrough infections are less severe in individuals fully vaccinated. This slide reviews the CDC's ACIP vaccine priorities when initial vaccine supplies were limited. Generally, the first tier to be vaccinated were frontline healthcare workers and long-term care residents. Healthcare workers needed to be protected to staff hospitals and clinics. Long-term care residents had high rates of severe disease and death from COVID-19 infections. This was followed by other high-risk groups, including the older elderly individuals, those 75 years old and older but not in long-term care, and non-healthcare essential workers. The next priority groups were other high-risk elderly, like those 65 years old and older, individuals with high-risk medical conditions, and any additional essential workers not already covered. This was then followed by the general public. Let's briefly touch on the role for monoclonal antibodies and antiviral medications for outpatient use during the COVID-19 pandemic. Like a body's own immune system's antibodies, monoclonal antibodies recognize, bind to, and neutralize infectious agents. The human immune system produces many types of antibodies in response to infection and vaccination. These antibodies come from immune cells called B cells. Each B cell produces only one kind of antibody and makes many copies of it. However, only 2 or 3 of those antibody types might be effective at neutralizing the COVID-19 virus. In the case of COVID-19, the most effective antibodies are those that attach to the viral spike protein's receptor. This attachment can stop the virus from invading a cell, preventing the virus from replicating in the body. Scientists in a laboratory setting can synthesize massive amounts of antibody directed at targets like spike protein receptors. There are numerous anti-COVID monoclonal antibody products available along with those listed on this slide. Unfortunately, the various monoclonal antibodies are not equivalently effective against all COVID variants. For example, the only monoclonal antibody showing efficacy to treat mild to moderate disease from the Omicron variant is sotrovimab, a GlaxoSmithKline product. Most monoclonal antibodies are used for treatment and post-exposure prophylaxis. They are administered by infusion or a series of injections. The supply of monoclonal antibody was often limited. Therefore, monoclonals were primarily recommended for individuals at high risk of severe disease. Pre-exposure monoclonal antibodies like Evusheld were used to prevent disease in individuals with significant immunodeficiency and those who were not fully vaccinated who had severe allergic reactions to the vaccine. This diagram demonstrates how anti-spike protein antibodies attach to the spike protein targets on the outside of the viral nucleocapsid. This attachment blocks viral spike proteins from attaching to human cells and infecting them. This table lists 3 antivirals that are available for the treatment of COVID-19 in an outpatient setting: Paxlovid, remdesivir, and molnupiravir. Paxlovid and molnupiravir are oral medications, and remdesivir requires intravenous infusion. Paxlovid reduces the risk of hospitalization in COVID patients by 89%. Paxlovid was authorized for use in patients 12 years old and older who have tested positive for COVID-19, regardless of vaccination status, and are at high risk, including those with underlying medical conditions like obesity, diabetes, and immune suppression. The drug needs to be administered within 5 days of infection, and best if started within 72 hours of infection. Paxlovid is administered in 30 doses over 5 days. An initial problem was supply and distribution. Paxlovid reportedly works against the Omicron variant. In May 2022, the CDC alerted healthcare providers of a COVID-19 rebound of symptoms associated with positive antigen tests after Paxlovid treatment. Rebound occurs 2 to 8 days after discontinuing Paxlovid and can occur in 1 to 2% of individuals treated with Paxlovid. Rebound symptoms are generally not severe, but these symptomatic individuals can transmit the infection to others, therefore should return to isolation. Individuals with rebound can end their second isolation period after 5 days if their symptoms are improving and they haven't had a fever in 24 hours. They should continue to wear a mask around others for 5 additional days to complete the CDC recommended 10 days of isolation and masking. Remdesivir is made by Gilead, is given intravenously, and reduces time to recovery from 15 days to 9 to 11 days. It can be used in those 12 years old and older. Merck's oral drug, molnupiravir, received FDA authorization on 12/23/2021 for infected individuals who are at high risk of severe disease. It should be started within 5 days of developing symptoms. Molnupiravir is limited to situations where other FDA-authorized treatments for COVID-19 are inaccessible or are not clinically appropriate. Molnupiravir is apparently 50% effective in reducing hospitalization. Let's now briefly discuss effective messaging strategies. These next few slides are not meant to be exhaustive, but provide some key points regarding public health crisis communications. During an epidemic, pandemic, or any other major crisis, consistent messaging from all levels of government leadership is extremely important. Coordination of messaging during large crises like COVID-19 is generally coordinated through an incident command process called a JIC, or Joint Incident Command, covering multiple agencies, levels of government, and other stakeholder organizations. The three attributes of good crisis communications include: be first with the message, which shows that leaders and spokespersons have good crisis situational awareness. Be right, meaning the information given is currently as accurate as possible. In public health crises, this means the information is generally based on science. The third attribute is be credible. Credibility isn't a value leaders can somehow magically create in the midst of a crisis. Credibility is built step by step throughout a leader's life. During a crisis, a leader heavily relies on that store of credibility, honesty, and integrity to effectively communicate to the public. This diagram is adapted from Dr. Peter Sandman's book, Responding to Community Outrage. I would highly recommend this book for anyone in public health leadership. There are two scales on this diagram, including level of hazard or real public risk that ranges from low to high, and amount of concern that ranges from none to outrage. The blue oval represents a situation of low concern and hazard, the area of no concern or problems. We would love to live in that oval, but that's not reality. The red oval is the area of high concern to the point of outrage, but low real public health risk or hazard. There is a strong element of irrationality and emotion in outrage. According to Dr. Sandman, special skills in outrage management are required to handle situations like this. Statistics are generally not the answer in these irrational emotional situations. Outrage requires a different approach, a more human, feeling, understanding approach to the public, saying things like, "I understand your concern and we will get through this situation together. I'm with you." That's often difficult for public health scientists who are primarily people of statistics and data. The maroon oval represents a true crisis associated with high concern and high real public risk or hazard. This is a true crisis. In those situations, a public health leader needs to utilize classic crisis management skills. The green oval is the area of public apathy, where the public hazard is high, but there is relatively low public concern. Chronic diseases and injury prevention finds itself generally in this area of apathy with minimal concern, though the hazard is medium to high. In this situation, strategies are needed to move the concern factor to the sweet spot where people are concerned but not irrational, stimulated to change high-risk behaviors associated with chronic diseases and injury. The COVID-19 pandemic seems to straddle attributes of outrage and true crisis, as outlined by the blue box, requiring both outrage messaging skills for much of the population who will only manifest mild or asymptomatic disease, and true crisis messaging skills, since COVID-19 may kill significant numbers of those at high risk. Let's now focus for a few minutes on the crisis communications of pandemics, like that of COVID-19, using an outline developed by Bernstein. There are several pre-crisis steps that organizations, including public health, should complete in preparation for crisis communications. First, identify a crisis communications team, and that team needs to anticipate crises. A small team of senior leaders should be identified to serve as the organization's crisis communications team. Ideally, the organization's chief executive officer will lead that team. Crises will happen, like COVID-19. An organization's crisis communication team should regularly hold brainstorming sessions to identify potential crises that could involve the organization. This crises list will provide a valuable planning path for the organization's crisis communications preparedness plan. Next, organizations should identify a spokesperson or spokespersons for crisis communications. In large agencies or organizations, there may be multiple spokespersons representing various areas of expertise. Appropriate spokespersons must have the right skills, the right position, and the right training. In a crisis like COVID-19, the chief executive officers are often required to be the lead spokesperson for the agency or organization. Spokespersons should be identified and trained in advance. This crisis communications training is critical and often assigned to the organization's public information officer. Next, it's important to identify and know your stakeholders and establish notification and monitoring systems. Knowing an organization's stakeholders is critical, since during a crisis, they will likely be communicating with others about what an organization and its leadership are or are not doing. An organization needs to have strong key stakeholder pre-crisis relationships and trust. It's also essential to have notification systems established that will allow organizations to rapidly reach stakeholders using multiple modalities. Next, it's important to develop key general pre-crisis messages or holding statements. While full message development must await an actual crisis, holding statements or messages designed for immediate use should be developed and readily available. These holding statements can provide initial messages for a variety of crisis scenarios previously identified by the crisis communications team. When encountering a crisis, all the pre-crisis communications planning will help in the initial stages of the response. During a crisis, an incident command process should be used to coordinate all aspects of a response, including communications. During the crisis, communications will rely on assessment of the situation and finalizing and delivering key messages via the spokespersons trained during pre-crisis planning. After any crisis, it's important for organizations to do a post-crisis analysis. This is part of a performance improvement process and is a normal part of an incident command process, often titled a hot wash. This is the time to do formal assessment of what was done right, what was done wrong, what could be done better next time, and how an organization's crisis communications process can be improved. Let's now briefly discuss developing a triage plan. Let's look at our pandemic graph again. Effective triage is meant to prevent our hospitals from being overwhelmed. Effectively flattening the curve and changing some hospital processes we previously discussed could both help prevent that situation. If that's inadequate, hospitals will need to anticipate when to implement a triage system to deal with patient care needs. Triage may consist of implementing systems to quickly screen out the worried well and those that are mildly ill from those needing further evaluation and care. Screening can take place in many potential venues, including by phone, text, email, web-based, drive-through, remote location, etc. With limited life support capacity, triage may include difficult determinations of who will and will not be provided intensive care. Triage plans must be developed as part of a comprehensive pandemic plan. The next few slides describe some key outpatient monitoring protocol concepts adapted from protocols used by the New York City Presbyterian Hospital to help decrease hospital impact during the COVID-19 pandemic. A clinician determines whether outpatient monitoring is indicated for a patient with COVID-19, either post-hospitalization or when diagnosed in an outpatient setting. Outpatient monitoring for asymptomatic or mildly symptomatic patients would be via home isolation or quarantine, usually monitored by state and local public health officials. Outpatient monitoring for symptomatic but stable patients who have fever and cough would first require a home assessment to determine whether an individual should be placed on home monitoring or in a regional monitoring institution. Home assessment should include answering the following questions. Does the patient have adequate access to daily living necessities? Does the patient have appropriate home caregivers, or do they have the ability to self-care? Can the patient reduce transmission risks within the home by having separate bedrooms, adhering to home isolation, practice respiratory and hand hygiene, etc.? Are there other household members at increased risk of COVID-19? Does the home have appropriate personal protective equipment like masks and gloves, etc.? Does the patient have adequate access to a hospital and emergency transportation services? Home monitoring may be most appropriate for those living in proximity to a hospital capable of handling COVID-19 patients in acute respiratory distress. Consider placing all patients who fail to appropriately meet the home assessment criteria in regional monitoring institutions, RMIs, until the risk of respiratory deterioration is deemed unlikely, which is usually 11 to 19 days after symptom onset. Outpatient monitoring may include the use of an oximeter to measure oxygen levels and oxygen concentrators or other sources of oxygen. If the patient has an exertion O2 or oxygen level greater than 95%, no oximeter or oxygen source is required. Exertion oxygen level means measuring the oxygen level after walking approximately 30 feet. With an exertion O2 greater than or equal to 92% to 95%, an oximeter would be recommended. With an exertion O2 less than 92%, an oximeter and oxygen source, like an oxygen concentrator, would be recommended. Home monitored patients should seek medical care immediately if they have trouble breathing, persistent pain or pressure in the chest, new confusion or inability to arouse, or cyanosis, bluish lips. Patient disposition should be discussed with a COVID-19 clinical expert if they have the following: worsening cough or shortness of breath, oximeter level at rest or with exertion less than 90%, or need to increase oxygen flow if on oxygen. During pandemics like COVID-19, numerous huge decisions need to be made that impact multiple stakeholders in the public. The National Incident Management System, NIMS, was developed to not only help make those big decisions in a logical, systematic way, but also implement them. NIMS standardizes incident management processes, protocols, and procedures for use by all responders. Incident command. Learn it and use it. You'll need it. Other resources available to support hospital surge capacity includes State Medical Reserve Corps and federal and state medical caches. The Medical Reserve Corps are volunteer professionals who have agreed to provide their services when called upon. Federal and state medical caches consist of various disaster support supplies, often including medical equipment and medications. The content of the state caches varies greatly from state to state. These support services are organized and administered in different ways in each state. In many states, the state health department is assigned to administer these support services, which requires a significant, ongoing, advanced planning, funding, and other resources to maintain. In summary, adequate herd immunity for COVID-19 would require at least 92 to 94% of the population having protective immunity to COVID-19. Protecting vulnerable individuals is essential to reduce morbidity and mortality. Developing a COVID-19 vaccination plan is extremely important. Utilize an effective home monitoring plan for those on isolation. Both outrage and crisis communication strategies apply to pandemic messaging. The incident command process is essential to coordinate crisis response.